This is Donna at the AJCC. The topic for the webinar is Do Not Use Registry Ambiguous Terminology for AJCC Staging. Now, AJCC had a harmonization summit in September of 2015 as we were working on the AJCC 8th edition staging manual. This was a large, multidisciplinary group of physicians, over 60 in attendance, along with many of our registry surveillance partners. We were reviewing the AJCC principles of cancer staging, looking at updating and modernizing and making some of the rules more explicit and easier to understand. One of the questions we considered was the registry ambiguous terminology list, and should it be used for AJCC staging? The AJCC physicians did not endorse use of the ambiguous terminology list, and they cited the variability in physician use of terms. This list does not match any use of medical definitions or medical terms that the physician community is comfortable with and uses appropriately throughout patient care across the country, across the region, and in many different areas. And often it is in direct conflict with the physician documentation in the record and the treatment that the patient receives. So AJCC does not define any ambiguous terminology, and we don't mandate how those words should be interpreted. So that's why those words cannot be used for AJCC staging. Now, when you're trying to determine cancer involvement, there are some guides on how to interpret the words for cancer involvement. It's very important to review the managing physicians or the clinician's statements. And if you noticed, I'm saying managing physician or the clinician, because that is the only one who has access to all of the information. So it's very important that you don't just take a pathology report or an imaging report out of context. You need to consider the entirety of the workup. Also, the treatment choices may indicate the managing physician's impression. You should review and analyze the entire case, looking at the physical exam, the medical history of all the diseases, the symptoms, imaging, lab tests, diagnostic procedures, and any and all other available information for that patient. It is really the managing physician's judgment call based on all aspects of the patient's care in determining whether or not those tissues are involved with cancer. Now, here's some examples. We have a lung case with the CT of the chest reports mediastinal adenopathy. The patient was scheduled for a left upper lobe lobectomy. Are the mediastinal nodes involved with cancer? Well, we know there's a lot of registry documentation out there that registry world always thought that adenopathy meant they were involved. But let's do some analysis of the imaging. Physicians have told us that chest x-rays are not very sensitive. And if the nodes are big enough, enlarged enough to see on a chest x-ray, they may be involved. But the CT, MRI, PET are extremely sensitive. And it could be infection, inflammation, an immune system reaction, or cancer. So there's a difference in the type of testing that is done. So when registrars thought adenopathy meant nodal involvement, that was true 40, 50 years ago on chest x-ray, but it's no longer true with today's more sensitive imaging. We also need to look at the treatment and analyze that. If you look at NCCN guidelines, surgery is not the treatment for mediastinal node involvement, which would be a clinical N2. So the decision for this case is mediastinal nodes are not involved. You could see, whereas if registrars strictly went on ambiguous terminology or registry rules, they would get it wrong. Let's look at another example. So we have a case of cancer in the duodenum. The CT abdomen pelvis showed a duodenal tumor with extensive inflammation, exudate, and adherent to other loops of small bowel. The patient was scheduled for a resection of that tumor in the duodenum. Now, does adherence mean other bowel is involved with cancer? Well, adherence is on the ambiguous terminology list for tumor spread. And if you went by that list, you would say yes. But let's look at the imaging and treatment analysis. Exudate is fluid leaking from blood vessels due to inflammation, and that inflammation is causing the adherence, not the tumor. If there was really extensive tumor adherence, they would not just be resecting the local tumor. They would need a much more extensive surgery, resecting all the other bowel that the tumor was adherent to, because it would be invading into those other parts of the small bowel. Or they would need chemotherapy or some other type of treatment to handle that disease that was spreading to other parts of the bowel. So the decision in this case is other small bowel is not involved. So again, you would see where the ambiguous terminology list that registrars use would lead you down the wrong path and not provide with accurate staging. And our last example, a case of cancer of the rectum. The MRI pelvis showed a tumor 8 centimeters from the anal verge, and it suggests stranding in the perirectal fat, and no mesorectal nodes were involved. The patient was scheduled for neoadjuvant therapy. Now, does suggest disqualify perirectal fat being involved with cancer? Now, if you look at the registrar ambiguous terminology list, suggests is a word that registrars have to interpret as not being involved with cancer. So let's look at the imaging and treatment analysis. Fat stranding can indicate infection, trauma, or cancer involvement, and fat stranding is a common way to describe rectal cancer involvement. But if you look at treatment guidelines for a clinical T3, which would be involvement of the perirectal fat, that is neoadjuvant therapy. Whereas if this case was only a clinical T1 or a clinical T2, with that clinical N0, because it said that the mesorectal nodes were not involved, that patient would have gone to have a surgical resection instead of neoadjuvant therapy. So by looking at the imaging and the treatment, we can make a decision that the perirectal fat is involved. And again, if registrars are using that ambiguous terminology list, it would lead them down the wrong path, and we would not have the correct information being recorded. So that's why it's so important that we don't use words out of context. Just because registrars have decided that's what the word means, the medical community isn't in agreement. So in summary, registrars really need to apply critical thinking when interpreting the physician's words. And we know registrars are definitely capable of doing this. They're able to look at that entire picture and understand what's going on. So registrars do not use the registry ambiguous terminology lists, but they must take into account all of the available information in deciding what the AJCC stage should be. It's also important to identify non-registry resources, such as looking at national treatment guidelines, NCCN, ASCO, the American College of Radiology appropriateness criteria. There's a lot of different information out there that can help registrars understand the documentation in the record from the managing physician. And it's important to obtain answers to your questions before making assumptions based on just single words that you find in the record. Because many times when you take it all into context and look at the whole picture, That's not what that word would mean or what that word would imply. Information and questions on AJCC staging can be found on our AJCC website. This graphic, Timing is Everything, is available on our website. It really helps registrars to understand the time frame, which are in the arrows, and the criteria, which are in the square boxes, for clinical, pathological, and post-neoadjuvant therapy staging. Our website can be reached by doing cancerstaging.org or the longer URL from the American College of Surgeons. Our pages include important information, such as in our overview, version 9, information about our cancer staging systems, both the 8th edition and version 9. And there is a free download there for Chapter 1, Principles of Cancer Staging, if you need that. There's cancer staging education and frequently asked questions and other resources. Of course, you're always able to submit questions to Cancer Forum. We have a specific forum for version 9 and one for 8th edition. They're located within Cancer Forum. And this way, it really helps us to understand the types of questions that are being asked so we can direct our education to those hot topics. Also, it provides the information not only that you may need when you post a question, but it helps other registrars who are looking at your question and maybe they have a similar one, and that's providing an answer for them. This was developed through generous support from the American Cancer Society, and we'd like to thank them. And I'm Donna Gress, and thank you for your attention today.